Thank you, everyone. Once again, I would like to thank the three Egyptian professors for the fantastic hospitality and for the kind invitation. The degenerative part of the meniscus has been already nicely addressed by Dr. Chinson, so I will really focus on the traumatic part of the meniscal injury by really emphasizing to save the meniscal function and not only saving the meniscal structure. I have no real disclosure related to this talk. Once again, we all know the different features of the meniscus, and I will again emphasize the stabilizing effect of the meniscus when, especially in loading condition. Well, the meniscus has also a very nice and fusional relationship with the cartilage. When you see this nice sectioning coming from an imagery, you can see that where the meniscus sits, there is not much cartilage around it. So if you remove the cartilage, if you remove the meniscus and your cartilage is not covered anymore, you may see that the lesion will be easily present. Don't forget either the meniscus can heal. We very often hear that the meniscus cannot heal. Actually, the meniscus can heal, at least in the periphery, and sometimes those cells can migrate up to 2/3 of the width of the meniscus. Well, so far we have looked at the meniscus on the structural way for making our classification. Very recently we updated those classifications by adding all the insertion lesions that are related to the medial or lateral meniscus. Well, a few years ago, we developed this figure of 8, I would say, way of looking at the medial and lateral meniscus by meticulously not only looking at the meniscus, but really palpating it, mechanically testing those meniscus to see if they are stable, if they are mobile, if they have some lesions that are not hidden but neglected if you don't look at them properly. Well, looking at that, we look at 3 consecutive patients who had an ACL tear, and we applied this technique, and you can see that we found quite a lot of meniscal injury in these patients. On the medial side, we had quite a number of ramp lesions, meniscosynovial lesions, but also a lot of Beckett-Endel and longitudinal tear. On the lateral side, interestingly, and that will be one of the point of my talk, we found a lot of injury around this hiatus popliteus, and I will come back later to that. Well, regarding the treatment on these lesions, most of them, as you can see, has been repaired, at least on the lateral side. On the medial side, when you have a central lesion on the medial side, it is sometimes be difficult to make those healing properly. Well, if we compare those data to the literature, you can see that isolated ACL is something probably relatively rare nowadays. Most of these injuries are, I would say, concomitantly associated with meniscal injuries. Well, now if you want to have, let's say, a modern approach of it, if you are on the medial side, you have to look at those different injuries. Now, if you have an isolated Beckett-Endel tear that is, I would say, more central than 4 millimeters from the periphery, especially in the heavy athletes, probably it's not worth trying to repair it because the failure rate is very high. On the lateral side, again, I think it's a little bit more complicated that we used to look at it, especially on the, again, stability aspect of this lateral meniscus, but we'll come back to that later. Ramp lesion has been already mentioned this afternoon. I will not stop by there. The thing, this is the message, always looked at it by doing transcondylar. I mean, this should be part of your routine to go transcondylar. And if you are some doubts in transcondylar, well, use a posteromedial portal to really have a good look at your meniscosynovial attachment and try to pick if the ramp lesion is there or not. How to repair it has been already shown. You can use a 1 or 2 posteromedial portal approach using the hook technique, and you will secure the meniscus back. Well, now we know that we can address some of those lesions with, I would say, the all-inside technique that we used to use in some meniscal injury, especially in the lower injury. You have here one example. When you look from the front, it doesn't look bad. The meniscus looks okay, but when you go cantilever, you're on the posterior medial aspect, you can see this lesion here. And you can fix it, because this was an inferior one, you can fix it with an all-inside technique by using superior and inferior sutures in order to restore the stability and the fixation of the proper meniscus. Then you will have always to go back in the posterior medial aspect, make sure that your meniscus is well reduced and well fixed. That has been shown by the Andy Williams and Andrew Amy's team that this was very, this was feasible and effective in fixing those lesions with this all-inside technique. Now, coming on the lateral side and on the lateral meniscus, what we call now the posterior belt that is constituted by the attachment of the lateral meniscus, the central part of the meniscus. You have already heard about it, including the root lesion. But not only, we know that around the popliteus tendon, there is no so-called complex popliteomeniscal complex that you can see represented here, with some ligaments like the fibulomeniscal ligament, like the meniscotibial ligament, that is concerned by the lesion. And how does it happen? Actually, when you have such an ACL tear, you can see the subluxation of the tibia below the meniscus. And this subluxation will obviously pull all the meniscus and this posterior belt anteriorly, as you can see it here. And obviously, when you have such a subluxation, you will easily imagine that you can uncap or unlock all the belt, either at the root or at the around the popliteus tendon. Well, looking first at the root, there is several classifications that have been published. You can use the one you are the most suitable one with. Recently, Crick and all has also make another classification, arthroscopic classification, that allows you to choose which technique you will pick to try to repair this root. Well, we have recently, with Romain Zeil, added one of those, one stage to this classification. This is so-called the insufficiency of the root. I will come back on that. Well, when you have a complete root tear, obviously we like to use the transosseous technique with the pull-out repair that we pass transosseous by an isolated tunnel and not through the tunnel of the ACL to be anatomical and to offer a better fixation. Now, again, indication to all inside root repair. Yes, we have in this so-called root insufficiency situation where you will look at your posterior horn and you see that your posterior horn is more mobile than normally. And when you look at the root is loose and can be easily maneuverable. In this case, you will try to refix or retain the posterior horn by fixing it articularly, but it's all inside technique, as you can see it here, Dan, which will allow you to really retain properly the posterior root of the meniscus, and therefore restore once again the meniscal stability. Well, there's been now well supported by the literatures that will clearly increase the different mechanical features of the lateral compartment when you do that sort of treatment. Where sometimes it's more subtle than that. You can have, as described, again by the team of Luxembourg, a posterior horn instability or laxity that you need to address as well in the same time by all-inside technique. Or more recently, we described not only the hypermobile lateral meniscus, but a hypermobile lateral meniscus associated with a posterolateral corner rotational instability. And in this case, you need also to fix the meniscus. And you can fix now arthroscopically, we have shown it with a result, by all-inside technique, and you will neutralize the rotational laxity as well. Well, finally, the radial tear. This is always a formidable injury for young athletes, for the surgeon. We always try now to repair those using either hashtag technique or cross-pipe technique in order to really try to reduce and refix the meniscus. But those are clearly, I'll say, a very challenging injury to get healed, and you have to really be very, I would say, cautious with the return to loading condition in this type of injury. Well, when we look at what says the literature, actually the literature is very supportive in repairing all those, let's say, meniscal fixation and meniscal injury in order to achieve better results. Well, the take-home message is that you have to do a systematic examination of the meniscus integrity and stability, palpate your meniscus, test it to make sure that your meniscus is stable, repair as often as possible, especially on the lateral side. This is particularly important. Preserve meniscal tissue as much as you can. Again, notably for the periphery, use the technique you are familiar with. There is different technique. There is cheap technique out there that you can use that will favor your fixation of the meniscus. And when it's well performed, when it's associated with a well-performed ACL reconstruction, it really results in good and durable outcomes. And with that, I will invite all of you in our specialty day, ESCA Specialty Day in Warsaw in November 2023, and obviously to the ESCA Congress next year in Milan, where we will speak a lot about meniscus. Thank you very much for your attention.